Dear colleagues, welcome. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. Today we are tackling a silent crisis in our clinic. We are treating obesity as a matter of weight or appearance, but inside the body, much more dangerous processes are unfolding, one of which MASH, or the metabolic dysfunction associated steatohepatitis. Join us today to navigate this with Dr. David Macklin to explain why the liver is ultimate victim of metabolic syndrome. In family medicine practice, we are the gatekeeper. We see patients long before they see other specialties. We often hear about fatty liver almost casually, like it's a normal part of aging. But what about the dangerous cousin, MASH? To simplify this, ladies and gentlemen, it's our pleasure now to identify that MASH is when a fatty liver becomes angry and inflamed. Think of it as a wound that won't heal, eventually turn into scar or fibrosis. David, welcome to Jeddah, and I would like to welcome you here in this podcast, and I would like you just to shed a light on how the primary care physician in 15 minutes consultation can address the issue of MASH. Okay, David, you have mentioned that MASH is a silent because there is no symptoms till it gets complicated. How do you explain this for me?
So yes, now for our listeners, thank you, Dr. Ashraf. We now have a context. We've described that some individuals are at risk of, because of appetite dysregulation, excess adiposity, and weight gain and developing obesity. One of the places that the excess or ectopic adiposity can go to is the liver. And this is an asymptomatic phenomena. So let's describe this. What are the pathophysiological reasons why fat will deposit in the liver, and what are the consequences? Very important for the primary care doctor. So to start with, we may have a patient who may, on ultrasound, be shown to have fat within their liver. We may have a patient who has impaired glucose tolerance or high triglycerides, or they have low HDL. We start in that group, that high-risk group, to suspect that they may also have deposits of fat in their liver and be at risk of MASH. So how does this take place? Think about it this way. Maybe it's easy for everyone to understand that first, there is an overproduction of fat in the body. Because of insulin resistance, the fat cells themselves undergo lipolysis. So there is a wave of free fatty acids leaving the fat into the circulation, and these arrive at the liver. Mm-hmm. Second, there is a process called de novo liver lipogenesis. And so there is a creation, paradoxically, because we don't need it at that point. The liver usually is very good at making fat, but here it's making too much, de novo. Also, there is a blocking because of a process within the liver, a blocking of export. So too much made and arriving, then too much made inside, and then not enough leaving. And so we have these excess deposits of fat cells within the hepatocyte. Mm-hmm. And just that we call steatosis. We call steatosis, fatty liver. But then, and we don't know exactly why this happens in some people and not others, and we do know that there is a strong genetic vulnerability, in fact, a unique genetic vulnerability in the Kingdom of Saudi Arabia, where individuals have genes that make the next processes that lead to disease happen. So the next process is inflammation. The excess adiposity within the hepatocyte, the excess fat, starts to misshape the hepatocyte. It starts to swell. This also is associated with a process of inflammation. And then this inflammation and swelling can also lead to fibrosis. There is a staging process to start to describe these next steps. There is a scoring system from F0 to F4. Okay. And these are stages going from no fibrosis all the way to cirrhosis. And each of these stages is a stronger predictor for disease. The leading cause of death for someone within this process is not end-stage liver disease. The leading cause of death is heart disease. This is a leading and primary risk factor for heart disease. And for the primary care doctor, the process is to recognize this and catch this early, because otherwise left untreated, like you said, an angry inflammation and wound that is not healing, this process is what leads to comorbidities, further comorbidities, and mortality.
And what are the tools that the primary care physician can use to early diagnose MASH?